بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. It is my pleasure to be with you today in the Egyptian Hypertension Society conference. Thanks a lot for the organizers and inviters for inviting the World Hypertension League to share this elite gathering. Self-management in hypertension care is a cornerstone in the care, which has been very well settled in the guidelines. However, there is modest maybe coverage by its importance, how it has to be implemented, and as well its components. In this coming a few minutes, we'll go through these and highlight the issues related to them. We do all know that many of the guidelines and as well many of the efforts, whether they are training efforts or research efforts, has been paid for screening, clinical assessment, and as well pharmacological therapy. And this is very well supported by the industry, whether it is the pharma industry or instrumental and lab industry. However, the non-pharmacological management is one of the main care issues that have been not well covered, not well discussed, and as well modestly really reviewed in research and in educational gatherings. The main core of the non-pharmacological management is the self-management, and we do mean by the self-management is planning self-management by the health providers so that it will help the patient to be actively engaged in his care through a very well customized and agreed plan that is really doable by the patient. And it is the core of the whole hypertension management. We cannot really talk about pharmacological management while we are not really having good compliance by the patients and good intake of his medications. On the same issues, we cannot really talk about a good pharmacological plan without having a good assessment through also secondary causes and comorbidities and cardiovascular risk assessment. And all these would need for at least multiple of sessions that the patient needs to comply with, and as well lab tests which will cost not only money, but it will cost as well time and maybe really suffering of the patient while his blood pressure may be not in a good, but the patient is not in a good mood to comply with all these requirements. The components of self-management really is very diverse, as you can see in these slides. It goes through whether the home care, the change in the lifestyles, as well the psychosocial part of it, and in addition to that, many others that the patients must cope with in his work and his at home as well, including his travels here and there. Let's go through them one by one briefly. One of the issues that it is a must for every patient to know and understand his current situations. Many of our patients, unfortunately, doesn't know even their numbers, whether the current blood pressure figures or the target figures that we are aiming to reach with the patients. And this has to be really discussed clearly with the patients, including his cardiovascular risk as well, so that the patient will be in a good situations to decide and to agree and decide and as well comply with any plan set by his care provider, whether this plan is pharmacological or non-pharmacological. There are multiple ongoing health problems that hypertensive patients used to present to, whether they are other cardiovascular risk factors or some other chronic diseases, whether they are physical or non-physical And we know that the non-physical and psychological problems are very common in hypertensive or in any chronic disease patient as general. Patients need to not only understand, but to be aware about these chronic problems and how they really come to discover them while we are working up the high blood pressure level. And in addition to that, he needs to know how to really fulfill their needs of healthcare and how to address them, because it is not enough really to address the high blood pressure while the patient is having some other problems that will hamper the care. For example, depression will hamper the care and the compliance of the patient for any plan of management. The regular follow-up of the patient may be the cornerstone of self-management. We cannot really address and empower our patients without having him in regular follow-up, because we cannot really address his needs in one visit. He needs usually multiple visits, especially at the time of the diagnosis of high blood pressure, or at the time of the diagnosis of a target organ damage or comorbidity. All these make a burden on the health system, the care delivery process, and as well the patient to comply with all these requirements of regular visits. These visits, without being regular and having some reminders here and there to catch up any pitfalls in the follow-up, will make the plan setting really difficult, delayed, and maybe really obstacled by many of the care delivery problems or the insurance issue coverage, or at least the psychosocial status of the patient from time to time. So proactive care would be another cornerstone in this regular visits. We cannot wait for the patient to ask for the visit. We have really, once the patient has been discovered, we need to put him in a care plan that's proactive in calling the patient and provide him with the needed visits that will set and settle the plan needs. The medication awareness is needed for every patient, and this is another element of the self-management. The patient may not be aware about the dosages, the side effects, the common side effects, the serious side effects, and he may approach them wrongly, or at least if he doesn't know, it will affect the doctor-patient relationship and the trust of the patient towards his physicians and care provider. In addition, he must be aware about the cost on the long run, especially if the insurance is not covering his health needs. In addition to that, he needs to be aware about how to monitor the response, the tolerance, and as well the side effects of these medications on the long run. We know that most of our medications, whether they are diuretics, RAS inhibitors, or beta blockers, having some side effects which the patient may notice or may not, and it may be only noticed by doing some lab tests. The patients must be aware about how to store his medications and how to deal with any missed dosage. If I missed today's early morning, what to do with this? Shall I increase the dose of the next timing, or I have just to replace it, or just to miss it and forget about that? and how far this will affect his blood pressure control and his health in general. The patient must be aware about the importance and significance of lab workup. Many of our patients may do think that the lab workup may be needed at the time of the diagnosis, or maybe once something raised, whether it is a symptom or a sign. But as we all know, that lab workup is needed from now and then to monitor the health of the patient, to monitor the side effects of medication and the effect of the medication. And in addition to that, cardiovascular risk assessment. From other perspective, we need this lab workup to reflect the holistic reading and assessment of the patients. And the patient needs to know what are these lab workup needed and why they are needed. The home care, the patient needs to take care of himself to monitor his blood pressure, blood sugar, maybe weight from now and then, especially if he's on a plan of weight management. He's having some heart failure, for example, that will add to the care of the patient. If he's having diabetes, for example, will increase the need for food care, regular food care as well. Among the other self-management components is the dietary correction, whether it is salt or carb reduction, or increasing the vegetable consumptions, or just following the DASH plan. All these has to be through a very well structured, guided dietary plan, and not be left just for the patients to read and really to get some approaches which is not fulfilling the needs. The other issue is the other lifestyles changes, whether it is the physical exercise, the smoking and alcohol avoidance, which has to be addressed through a structured behavioral change plan. And we do need to know how to address this behavioral change plan. This cannot be done by one visit, but has to be very well structured, and the care providers must be trained for that very well. One maybe of the last components is the psychosocial adaptation of his problem. The patient may ignore or reject and doesn't accept that he's having a disease. He may would say that, oh, my high blood pressure is just as an end result of some stresses I'm passing on. He may be right to an extent, but he has to be followed for that, and to show him that he's having a chronic rise of his blood pressure that is detected as a disease and has to be addressed through a very well structured plan of both components, the non-pharmacological and the pharmacological parties. And he may need from now and then to change his how he deals in his home circumstance, his work. We know that many environments may add to the rise of blood pressure, whether the pollutions, the maybe as well audio pollutions, the stresses, the long hours, the sleep deprivations, the timing of medications with work. All these will play some issues in coping of our patients with his plan of management. So we need to adjust it with his work. Some of our patients may do travel now and then, or may travel in a long journey, or may travel, for example, for Hajj or some other journeys. We need really to sit with them how to suit the plan of management with their needs during travel. How to set all that? As you can see, many of these issues and the self-management are there, make the life of the care provider as well as the patient very difficult really. How to set all that? We need to put it in a stepwise. We need, first of all, to build a good mutual relationship with our patients. We need to assess his views, his interest. Is he interested really in changing his lifestyle, in changing in treatment as a whole, or not? And we need to explore his healthy as well unhealthy habits and how far these healthy habits will affect his health in the future, and as well control of his blood pressure and cardiovascular risk, and how far his bad habits will affect that or hamper that. Salt, for example, per se, many of our patients doesn't really aware how far salt will make some of the medications almost useless. And we need to develop a plan and implement it for change, which is to be gradually and suit his circumstances, not really to give him all the plan together, but we need to have it step by step. We need to document our plans and as well to document our next plan so that once the patient comes, he knows what, and he expects what will be discussed and what will be really expected from his side or her side, and as well from the care provider sides. By this, hopefully we will get better compliance and control, not only for the change of lifestyle and dietary, for example, and the circumstances of the work or home, but as well in the pharmacological and the assessment plans. However, we need to prioritize this self-management because we cannot really give a lot of changes or any change if the patient is having a status of urgency. Here, the urgency will be number one to settle rather than to go for any other changes. And when another issue that will help us to prioritize is if the patient is on a plan, in any plan, most of our hypertensive patients will say, oh, okay, I know that my blood pressure was high for this couple of years. Okay, what have you done? And how far was it successful? And what make it not successful? And this will affect to prioritize and make use of the interventions that was successful but not continued on, rather than to go for the unsuccessful trials. And those which are not successful, which we need to discuss with our patients, why not successful? One more issues, how far the patient is trusting me. We cannot go for any self-management plan without building a good trust with our patient. If I do feel that the patient is trusting me, I will go ahead, and it cannot be really go without taking a permission. We need to knock the door. We need to inform him what we are going to discuss and whether he accepts me to discuss all that. If he said, no, I'm in a hurry, I'm not accepting that for now. Oh, I have been visiting a good specialist number so and so. This all may be some signs that he's not in a good mood to give me that trust at the moment. I have to delay maybe discussing a better plan in another visit. And we would really assess how my patient's ability to comply. And this depends on how the good assessment of the psycho and the social status of our patients. All these will help. We need many tools to be used. And among these tools which we can use in our patients are may be available in many places. For example, this is a tool which can be given to the patients to explain for our patients why do we have to have him engaged in the management of his high blood pressure. And it is not only to say that this is a magic pill to take to control your blood pressure. This is, for example, a tool that will describe the journey of hypertension care so that the patient will be expectant of what will be going on. This is the home blood pressure log diary that the patient can make use and mention on that what to do if and the target blood pressure or the figures that we are aiming to, and a few key messages in lifestyle management. This is the DASH plan, for example, and the DASH plan cannot be just handled this way. It has to be as well discussed, reviewed, and how to make use of it with our patients. In conclusion, the self-management is a mainstay for the non-pharmacological management. Our healthcare providers must be aware of what it is and how far it may affect the patient care, and as well the cost, and how to implement it. This has to be done by mainly maybe continuous educations, workshops, and courses, and how far the regular proactive follow-up visit is a base for this self-management, and the last but not the least, that health systems and the healthcare delivery must comply with all that. I know that this is a puzzle, but we need to, and this cannot be gone through without following the hypertension chronic care principles for excellence, which involve it has to be a patient-centered care, proactive, holistic, and to be integrated in a teamwork rather than one-man show. Thanks a lot for being with me for the last few minutes, and I'm keen to listen to your queries, comments, and thanks for all the organizers and inviters for arranging all that. Thank you.